Before we proceed further into the questioning, I just want to welcome one of our guest expert discussants, Dr. Rahul Argula from Medical University of South Carolina, where he serves as Associate Professor of Medicine and is part of the Pulmonary Vascular Disease program there. He has a special interest in pulmonary vascular disease in the setting of connective tissue disorders and serves on the PHA Center Review Committee as well. So please stay, Val. We'd like to have a interactive discussion amongst all of us, and sure, you can feel free to sit here. And we're still welcome to continue to accept audience questions. Looks like Dr. Mathai has something for us.
Yeah, so great talk, Val. So that patient you presented with scleroderma, I noticed the wedge was 14. So could some of her symptomatology and limitations be explained by occult HFpEF, and should we focus on that? Because what I see clinically is this, we think about the classic description of PPH in the 80s of being a 30-year-old, 35-year-old woman, and now it's a 65 to 75-year-old person where the comorbidities, as you noted, are much more prevalent. Phenotypic shift from someone with a pure precapillary component to maybe a mixed picture. Do you think we should be focusing on that?
Yeah, 100%, Steve. And I think I was like subtly trying to make that point, saying it's now 13 years later and her left atrium is big too, right? So she, I didn't show you her echo from 10 or 15 years ago. I mean, I do think she was a caught early scleroderma because of screening. If we didn't screen her, we probably would have never caught her. And so you see that, you treat, but now over time, she's older, her left ventricle is getting stiff. I mean, it is probably one of the things that is limiting her. I agree with you 100%. But it's what we're facing today, right?
Hi, I'm Carla Cruz from Prisma Health. I wanted to know what would be the role for exercise in those patients that are having limitations, but the resting echo and the resting hemodynamics are pretty mild and not leaning to this is all pulmonary vascular disease. Would there be a role to exercise those patients and see?
Yeah, so it's a great question. Sudar really highlighted the new exercise induced definition is not just a number; it really has to do with the slope of the PA versus cardiac output. And so, for patients with unexplained dyspnea who have normal resting hemodynamics, I think it's very appropriate to do exercise hemodynamics. I would also say that exercise hemodynamics are challenging in many, many ways, just in terms of exercise protocols and getting those measurements while someone is, breathing heavily and moving is one thing. The second thing to point out is that definition relies only on mean pulmonary artery pressure and cardiac output. And the point that Steve just brought up is really important because one of the most common causes of exercise-induced pulmonary hypertension is exercise-induced LV diastolic dysfunction. And so you also have to measure their wedge, which is challenging when people are exercising and breathing fast. But, we did a study at Michigan. It was Scott Visavati's, who's now at Ohio State, believe it or not. I still talk to him. But his K award was doing exercise pH in the scleroderma patients who we screened and who didn't have resting pulmonary hypertension. And more than half the time when their mean PA went up, it was because their wedge pressure went up. So you really have to think about diastolic dysfunction as well in that setting.
So I'm going to spice it up a bit, and I'd like all of your impressions on this. What do you say to folks who say we shouldn't do risk assessment? Treat everyone as aggressively as possible with 4 drugs, just like we do in heart failure. And then after, they respond, for people who respond wonderfully, then you can start peeling back drugs. And for those who don't respond well, they're going to need a lung transplant. So just like to hear your thoughts on that, all the panelists.
So I'm sorry. So you're asking.
He's asking you to do induction PAH therapy.
Just no risk assessment. If someone comes in with PAH, put them on 4 drugs.
Regardless of the severity of their disease.
Because some patients, we know that if you put people on 2 oral therapies, the majority of patients don't reach low risk status. So put people, max them out on therapy and then
IV for everyone up front.
Yeah, this is it. Vic would always talk about induction therapy, like cancer.
Well, it's certainly a very provocative question, and I think we all see I think we all see patients who seemingly respond, extraordinarily to one particular pathway or one particular agent and not to others. But I don't think we're at the point of having, the ability to sort of pharmacogenomically assess individuals and know what particular pathway will be most beneficial to them in terms of outcomes. Are you proposing that uh, down the road there may be some potential for de-escalation of these therapies if this is sort of an induction approach and control of disease? And yeah, it's a great question. I'd be welcome to hear what others think, but
Go ahead. I've been talking a lot.
I'm surrounded by, is everybody able to hear me? Yeah, there's a lot of expertise on this table, but Sudhar, that's a great question, and people have pointed it out as GDMT, like GDMT for PAH, goal directed. But I always struggle with the question of there is so much heterogeneity inside Group One. Like portal pulmonary is different, scleroderma is different, lupus is different, and you can keep splitting this group so much. So when you think about heart failure, I see a lot more homogeneity in that population that lends to the GDMT paradigm compared to something like PAH. And then you throw the comorbidity question that has been discussed quite a bit today, and it we see patients struggle so much with two drugs sometimes with side effects, and we have to often go back and then re-challenge them, take some ERAs off, for example. So I don't know how easy it is going to be to operationalize something like that.
And I will just add, I'm going to do something I don't like to do very often, but I'm going to put myself on that academic pedestal. There's absolutely no evidence to support that, right? Absolutely no evidence. And in fact, the one trial that we did that looked at 3 upfront with 2 was a failure. And then I'll also add cost, side effects, trouble. Like I don't think we're there. We would have loved to design Hyperion that way, but they wouldn't. There's too much risk. They wouldn't do it. Like, so, even though not everybody gets where we want with dual oral therapy, a lot of them
That
do.
was my question for you, Val. I mean, how much discussion was there? Because I would have loved to have seen it that way at a certain risk status, those 3 drugs.
Yeah. Yeah.
So, yeah.
Yeah. Okay. I'll tell you the story. So, I actually have this history of pH talk that I do for the fellows, and I've given this in various formats, and people love it. So the story of Hyperion was we were designing Hyperion while Stellar was going on, because we wanted it to be the whole portfolio of, from prevalent to really sick to the really early folks. And we would have loved Hyperion to be upfront 3 versus upfront 2. And Triton came out and everybody got nervous, right? And, if you have a patient population that half of them are going to get a lot better, have a 50-meter improvement in their hall walk, a 50% improvement in their PVR with just dual oral therapy. And so if you look at a upfront 3 versus upfront 2, and half of the patients in both of those groups are going to get that much better with just 2 therapies, the N that you need to detect a difference between upfront 2 and upfront 3 is enormous. And there's a lot of risk to that. And, the feasibility of enrolling it, blah, blah, blah. So that kind of went out the window just based on the feasibility of doing it. And so then we said, well, how about early within 6 months, which was the first protocol. And then we realized that, for those who were going on prostacyclins, that wasn't enough time to have them stable on dose. So then it got extended to a year.
Can I add that before Barb's question, if I take, I'm aggressive up front, but what if we take a public health standpoint, and these aren't like GDMT where we get $4 medicines at the pharmacy, right? We're then saying we have this small pool of people who can get assistance fund, and everybody knows virtually all of your patients get their money through assistance. And we now put everybody on 4 medicines instead of 2 medicines or 3 medicines, and pot gets smaller and smaller, and the population gets bigger and bigger because now we're going to include these left heart failure people who are falling into our CPC PH pocket, because we've lowered down the cutoff, which is good to make sure we're including people, but maybe we're also not including people. And does that matter, right? Do we then say, oh, we're gonna now my patient who really needs all 4 drugs can't get them because there's no funds left in the pool. Just throwing that out there. Not a question. I think you're up, Barb.
Thank you. Thanks, Val. Just wondering, from the risk assessment discussions, kind of thoughts about value of CPAT. Do we need to be doing more? I think the data are really poor, but it's a super powerful tool. And is there more value to longitudinally trending VO2s, other ventilatory efficiency data?
Yeah, great question. I actually am going to throw that to one of the pulmonologists. We don't do VO2 max testing very much. The folks who do it and do it well rely on it heavily. I just don't have expertise in that. I don't know if there's anyone here who does.
Yeah, I mean, I think it obviously needs more study, and I think it would be very useful to include it longitudinally in trials and registries.
Yeah, but
sure.
we fail trials when we use VO2. The
more prospective registries,
yeah,
more than trials. But yeah,
but the problem is that it's really a technical test, and like if the UCLA group could go every place and do VO2 testing on everyone, or Aaron Waxman's group could go every place, it would be great. But most places can't do it as perfectly as they do it.
It's certainly not as widely standardized as our other metrics, for sure.
It's very tricky.
Sorry, good, Barb. And there's other limitations, right? If you're already on supplemental oxygen, like how am I going to do an invasive testing? That's going to preclude a huge bunch of patients from even going through, evaluation for response.
That's exactly, I was going to make that same point. It's very tricky when someone's on oxygen because all of our patients need more oxygen as they exercise. Then you can't really do a VO2 max if you're changing their oxygen during the test.
So going back to Sudar's provocative question, my response would be, I think the side effect profile and tolerability of that approach would not be tenable for many of our patients, and that's based upon not only my clinical experience but also thinking about the recent analysis of the low risk population in the Ambition study. So going back, applying a REVEAL score, finding the low risk population, you see that the effect size and the side effect profile was worse in the low. It was still a positive study, but it was more problematic in a low risk population. So I think that there's signals that if people don't have severe disease, putting them on multiple drugs is probably not the way to go. And I view that a lot of my patients have scleroderma with the comorbidities, so perhaps that is more likely for them to have these side effects. But I do think that's a real consideration to counter your proposal.
I have a question sort of harkening back to the 2 cases that you presented. Did you by chance do the full REVEAL, including hemodynamics, on those patients? And does that put them in a different risk strata? And the reason I ask is certainly we're seeing a disconnect in many instances between the risk score and then when you start to look at cardiac imaging and actual hemodynamic measurements. Should we be more intentional and algorithmic, if you will, about repeating invasive hemodynamics in certain instances, or should there be triggers in our risk assessment algorithm to do that?
Yeah, that's a great question. Nobody tell Ray Benza. I haven't done the full REVEAL in I don't know how long. Long time. But it actually is a good point to see how the hemodynamics might pan out there.
And Val, if I may piggyback on top of Jimmy's question, again, we have a large scleroderma population. What you were describing is so similar to my experiences as well. You treat them for 4 to 5 years, they're getting better. You get an echo, the left atrium starts getting bigger and bigger and bigger. And in some of these patients have convinced them to get a repeat right heart cath, and sure, the wedge is high or the V waves are looking really crazy high. How often are you now starting to say, hey, there's this LV dysfunction, myocardial fibrosis phenotype in these patients as well? And are you, again, to provocatively use this, are you using an SGLT2I therapy in these patients?
Yeah, it's a great question. So there's, when we first diagnosed that patient, 13 years ago, there really wasn't very much evidence-based treatment for what we now refer to as LV failure with preserved ejection fraction, and there is now. So I would say yes. mineralocorticoid antagonists, SGLT2s, and even in some patients, GLP-1s are appropriate. I have to say, I personally, like, you all deal with this as well, right? Like, your clinics are so packed, like, to do all their PAH and all their HFpEF as well is challenging. So I usually like to try to get them co-managed with someone who really specializes in HFpEF and can get all that on.
Thank you.
Yay.
That's great, Steve.
I would ask the pulmonologist, so Jimmy's one, but and we have them up there, but in a cardiology clinic, I feel comfortable giving an SGLT2, but if you're a pulmonologist, is that difficult for you to even think of, like, oh, should I be putting spironolactone on this patient or pleuronone or, Jardiance, those things? Do we have pulmonologists in the crowd?
No, I definitely struggle with that. I would say I think definitely MRAs feel pretty easy because I use them so much from just potassium management and diuretic kind of thing. But I think just getting that hump over the hump of I feel good about giving appropriate instructions for SGLT2s and warning signs and when to stop or things like that. I feel like I'm close, but I'm not quite there. I've continued a lot of Lisa or cardiologist patients on SGLT2s, but have I gone to the point of actually starting them myself? I haven't, but I would love to have that comfort.
Yep.
And cost is an issue there too, right? So some people you're like, oh, can you get this? And yeah, not as easy as you wish.
Yeah. My preferred approach is to recognize that this might potentially benefit a patient and suggest that their cardiologist might prescribe it.
Yeah.
Yeah. So
Nobody ever gets started.
yeah.
That's fair, and I often gets put back on me too.
So Terry, I've been doing it for the last 3-4 years, again, in the shadows of our HFpEF group. And we've sometimes co-managed and, because of our geographical location, it's very hard for patients to go to 2 clinics, 2 appointments. So I've been using it. I mean, other than the urinary tract infection in postmenopausal women, I just counsel them a little bit. And then, I mean, it's a fairly easy drug to prescribe.
Great.
Yeah. So Val, I mean, I have one question for you. One is, we talk. I know a lot of patients. It's even in today's era, right? It's very jarring to talk about 1-year mortality and maybe 3-year mortality. Is it time to move past mortality? I mean, I know a lot of our clinical trials now are talking about time to clinical worsening, composite endpoints. Why do you think these metrics have not made it into our risk scoring systems?
Wait, if I could clarify your
Instead of just focusing on 1-year mortality survival,
Oh.
why are we not talking about, clinical worsening or composite endpoints in
I see.
day-to-day practice?
Yeah. So it's a great question. I think just the way that the data is collected, right? Because when you do time to clinical worsening in a clinical trial, you have a clear definition, you have an adjudication committee, right? Like you can really say most of the time, really say what clinical worsening is. When you look at registries, you don't have all of that data in detail. You don't have records from the hospitalization. You don't, I think it's just hard to get that data cleanly, whereas mortality is something that's, it's a yes or no question.
Can I ask just one more question? What did you end up doing with your first case that had the follow-up terrible hemodynamics and was already unfairly
Yeah.
complicated?
So, this is a controversial thing because, she really would not have fallen into any of the entry criteria
Right.
for any of the sotatercept clinical trials. She would have overwalked she would have overwalked Stellar and Zenith, and she was not recent enough to be in Hyperion. But we did put her on sotatercept. I think being at that age, pumping against a mean PA pressure of 80, she's not going to be able to do that forever. So we did put her on sotatercept. I know we've recast her and her numbers have improved, but I don't know what they are off the top of my head.
And were those second set of hemodynamics you presented improved from the original diagnostic?
Yeah, I think her original PVR was a bit higher than that. Her mean PA pressure was consistently high. Her cardiac output came up with her therapy, so her PVR calculated to lower, but still pretty high.
Yeah, very interesting. Yeah.
But she functions so well, and we all have patients like
Right.
that. And those are the patients that keep me up at night.
I would say that as a long-term treater of PH, right, I have patients that I've had since I was a resident and fellow who I've had for more than 25 years. And those are the people that, they're 20 or 30 and you're like, well, they have an echo that squeezes well, but is still gigantic. Their BNPs are normal, shockingly. And their mean PA pressure was 90 and now it's 60 and now it's 40, but they're 22. And so same, I don't know what to do with those people. They're very low risk by all the measures, but you look at that echo. But I treat them, or do I treat them, or do you treat those people differently than is my 20-year-old, do I treat differently than my 50-year-old? Then obviously different than my 80-year-old. But, I tell my patients that my goal is that you die of something other than your pulmonary hypertension, right? Which is easy to say when they're 75, maybe, but not easy when they're 20 or 30, right? Because then I'm like, oh, I got to keep you well for like 40 or 50 years. That's hard to do.
Yeah, the older I get, the younger 50 sound. So I
agree.
that patient.
If there are no other questions, Val, I'd like to leave you with one question. All these traditional risk tools that you've very eloquently described, these are in the era of, our traditional vasodilator therapy. Do we need to relook at these risk scoring tools in the activin signaling inhibitor era because of, some of the unique things it's doing to, coupling, resistance, MPAP?
I think it's a great question. I would love to see that. I've encouraged that sponsor to do a new sort of database for, a registry for a long time. It may get there, but I think it's a really good point.
Great. Well, I think we're running a little ahead of schedule, but that's okay. We've had a very robust discussion. So I think we'll close this session and go ahead and move on. Thank you, Val and
you.
Rahul.